Hello, everyone. I just want to welcome you to today's webinar, Supporting the Perinatal Loss Provider. I'm Kylie Hanish, and I'm founder of Return to Zero Hope, which is a nonprofit organization focused on improving mental health of families after perinatal loss. But we also do this through outreach, education, and advocacy work. So I'm so glad that you're here today for this very important topic that needs to be talked about more often. I will share myself that I am an occupational therapist by training, and I had a stillbirth with my first son, Norbert, back in 2005. And it's kind of led me to this place of, realizing that as part of supporting parents, we need to support the providers and educate providers on how to better support parents. So I'm excited that a lot of the webinars that we offer can be focused towards this. So today, we really want you to understand that you're not alone in your practice. I think that many of you feel isolated and alone, and there are not spaces to talk about your own experiences, whether it's with clients or what's coming up in yourself. And so hopefully that this can be a start of a conversation where we're being more open about this and that you feel less isolated. So I'm excited to introduce our speaker today, Jodie Hnatkovich. And she is in Pittsburgh, Pennsylvania. And I'm going to let her share, more about her credentials and her experience, but she's a therapist and also a bereaved mother. And so we met each other, I don't even know, maybe on social media. And then we got to meet in person at a conference. And so it's been nice connecting that way and just supporting each other, both professionally and personally, that we've both been through losses. So I'm going to turn it over to her. Thank you so much for introducing yourselves, and just use the chat feature as we go through today's presentation. And also, today's presentation is hopefully less of a presentation, but more of a conversation, rather than just like throwing a ton of data and references at you. It's like we want this to be more of an experience and a conversation. So from here, I will turn it over to Jodie.
Thank you, Kylie. I think we did meet on social media, and I think I had sent some families to when you were doing in-person perinatal loss retreats, and I think that is how we started the connection, and then we officially met 2 years ago at a conference in person. So I'm glad to be here, and I'm happy to talk about how to support the perinatal loss provider or reproductive loss provider, or whatever it might be, how language we want to use to work with it. The goals of this conversation starting out are simply to learn some language around the impact of perinatal loss providers. We know how important language is when we are working with our families. We understand whether we're calling it a pregnancy or a baby, or the baby has a name, or whatever the situation might be. We understand how important language is in helping families to feel valued and identified and seen. And so I want to just, hopefully we can name some things, give you some language, and help you understand that your experience isn't isolated and you're not alone in a lot of the things that you may be experiencing or that you're seeing other providers around you experiencing. So we want you to understand the impacts or symptoms and how you might see whether it's burnout or compassion fatigue or secondary trauma come up. And then we want to talk about some ways that you might be able to support yourselves. This is just very general basic information. We're going to talk a little bit about the research there, but also hopefully do an activity that you guys can start brainstorming and reflecting for yourself about what might be most helpful. Oh, I gotta actually click the button. So to start, who am I? This is me. I am a bereaved mother. May was our oldest child. She was born still on her due date, 8.5 years ago now, right? We all know that number when we think about it. And so for me, that loss has definitely impacted the way that I kind of move through the world. Even before that, I was already a trauma therapist. I worked with primarily youth families. And so I worked with families with kids that are experiencing bereavement of a parent or bereavement of a sibling, as well as like significant childhood trauma and abuse. And so I was working with those kids. Basically, once my loss happened with May, it was really hard for me to have boundaries with those kids and those families that I was working with. So I moved into this world of perinatal mental health and how do I support families. And so now I would say I'm a reproductive trauma and loss therapist. I specifically specialize with perinatal loss, with birth trauma, and with secondary pregnancies after loss or trauma, and supporting families in the family system within that. I'm also the owner and founder of a group practice here in Pittsburgh, Forward Wellness. And most recently, we started a nonprofit to help with educating providers, but also funding for reproductive mental health, because funding is sometimes that barrier moving forward. So that is me. My dear friend took this picture, which I really like, which is me and my two living children, and May as well in the photo. So let's begin the conversation. All right, so the first, Kylie, are you gonna ask the questions or am I just gonna?
Yeah, I'll ask the question. So talking about compassion and fatigue and burnout, is this something common to the perinatal provider, or is it something that just you have to be working for a long time for this to happen? Like, tell us about like what's common.
Okay. So compassion, fatigue, and burnout, we all know that language, but let's talk about shifting the other language. Another common topic right now is also this idea of moral injury, how we get into this field to navigate helping. We are in a helping profession. And then we see how the system actually sometimes prevents our ability to help in certain ways. And so the idea of moral injury is coming up. If no one's familiar with that, if you Google it, you can find some videos on moral injury. Where I talk about this as a trauma and loss therapist is by shifting the conversation to be, secondary traumatic stress or vicarious trauma. And so I understand that we're often talking about grief, right? We're talking about perinatal loss and we're talking about reproductive loss. We're talking about the grief that comes into that. My brain at this point in my life sees everything from this system of trauma and loss, right? Like all of the things come back down to this like base level human emotion. And when we really look at grief and trauma, it's really hard to separate the two, specifically when we're talking about perinatal loss. And that's because usually a perinatal loss also has a moment of trauma in it, because we often don't anticipate or expect that a baby is going to die. If you are here, I assume you are fully aware of the fact that babies do die, and we're kind of moving through that. So I don't feel like I need to sugarcoat any of my language within that, because this is the world we work in. But for most families, as well as providers, there's a moment of trauma because it wasn't anticipated, it wasn't what we expected. And so when I'm working with families as well as providers, we're looking at what is the moment of trauma and what is that moment of impact, if you will, where it becomes a psychological wound and something that we have to kind of move through and process through. I'm going to talk a lot more about that moving forward, but I think it's important to understand that I tend to use the terms trauma and grief interchangeably, and not pull them apart. And so in talking about secondary trauma, let's start there. One definition is that it's a natural consequent behavior or emotion resulting from the knowledge about a traumatizing event experienced by someone else. And it's the stress resulting from helping or wanting to help a traumatized or suffering person. And so that's that definition of traumatic stress. Traumatic stress is typically one something that happens once, like an event that happens one time and it impacts us and it creates a traumatic wound or a psychological wound. Whereas vicarious trauma is that secondary trauma, but it happens in response to a bunch of exposure to a bunch of things over and over and over. And so if we are exposed to perinatal loss or trauma or birth trauma or whatever it might be over and over again, we're looking at this idea of vicarious trauma. The reality is the symptoms that we'll talk about in a little bit are very similar, but I think it's really important to start with that. Next, prevalence, right? How often do we see this? Most of the research, I see Aubrey just put that she's a NICU nurse. Most of the research is on that Cheryl Beck, if you're familiar with Cheryl Beck, she has done, it's on nurses and medical providers or things like that. And so for NICU nurses, it's something like 49% meet the clinical criteria for moderate to severe PTSD. 49% of working NICU nurses. That's significant. 36% of midwives, 35% of labor and delivery nurses. And so understanding that, like, we'll get there, Sabrina, we'll get there. Some of us, right, we're going to be exposed to this. And so it's moving into this, how do we support ourselves moving through that? We don't have a lot of research on doulas. We don't have a lot of research on bereavement coordinators or on therapists even, and how they experience secondary trauma or in regards to perinatal loss. Hopefully there's more research coming out. I know a few people that are doing some research on that, but we don't necessarily know, for a lot of us, that this is most of our work is on perinatal loss support. Okay, and so the effect on the birth worker, for this, I just kind of pulled up like one study that I like to talk about over and over, but it basically says that when we're exposed to traumatic births or perinatal loss or whatever it might be, each event or family or loss, unless we are actively working through our own stuff and doing what Sabrina asked about, how do we guard against it, each one feels magnified, it feels bigger, and it feels heavier. And so what happens is we then struggle as providers to maintain an empathetic, present, professional role with parents and families. We then start to ruminate and obsess about what should we have done differently, what could we have done differently, which then means if we're doing that, we're not present with families in the moment because we're too busy in our head. We move through unhealthy coping skills, and we'll talk more about what that might look like moving forward. We're haunted, in this research it said haunted by secondary traumatic stress symptoms. I'm unsure about how I feel about that word haunted, but and then we consider leaving the career that we're in. Most people, like, we navigate this idea that we're burnout and then we leave. And then what happens? I think that answered that question. Is it common? Yes. And this is what it might look like with the people that we're, with our other providers that we're working with.
Yeah. So why aren't we discussing this? Is there stigma? I mean, if it's happening to 1 out of every 2 people, like in the NICU, as you in that study, like, why aren't we talking about it, and why aren't there more things being done, on a like systematic level for people working in the NICU, in the labor and delivery, that type of stuff? Okay, that was, sorry, I added on that question. You don't have to answer that.
No, I love the add-on. Why isn't there more being done? Let's start with what if we shift the language and we stop saying like if this happens, but when this happens, right? Like, we know we have a pretty good chance of knowing that if we are constantly exposed to perinatal loss and if we're exposed to trauma, like, we are going to experience this. And I'll talk a little bit about, like, the risk factors and things like that. But when we look at all of that, the reality is it's more of a when. because it is going to happen. And it should not be this thing that there's something wrong with us. We live in this society where there's a lot of victim blaming, and that comes down even to the provider. This assumption that like if you feel this way, it's because you weren't doing something correctly. And I want to just pull apart from that. So that kind of goes to Sabrina's question of how do we safeguard? I wouldn't say it's how do we prevent it, but how do we make sure that we're taking care of ourselves when it happens? And that's kind of the whole point of this. How do we lean into research and say, this is a part of our career, it's probably going to happen? How do we recognize it when it happens? How do we, take the necessary steps that we need to take care of ourselves when it happens? And how do we just give ourselves permission to feel and be in that space? I understand that is a very therapist thing to say, but that's kind of where I'm coming from, because then it helps us be present with our clients and our families and our patients that we're supporting, instead of living from this like trauma lens that we're scared of this happening again. Okay, so a couple things. When we're talking about the helper's career, I will go on a I'm going to take a guess and say 100% of us think of ourselves as helpers. And there's probably a reason that we jumped into a helper's career. It's, we can dig up all of that old family stuff if we want, but there's probably a reason why we decided we're going to save the world. And so there's some studies within the compassion fatigue about like the stages of the helping career. And so it cites this research that we start out as zealots. And so what that means is we start out really eager and we're hopeful and we are determined to change the world and make things better for everyone, right? We're going to do this. We're going to take it on ourselves. And then we acknowledge the reality of what's happening, and we become zombies. And so we become depressed. We kind of crash and burn when we realize that there's a lot messed up in our society and our caretaking and the way our hospital, like whatever thing we want to pick, right? We say like there's all this. And then we get discouraged. We're horrified by the work that we do because we're not saving everyone. We're not helping everyone. And we're unable to see past it. The next part, the next like stage is the misanthropist. So we go from depressed to now we're angry and rageful. We're pissed off at everyone. We're pissed off at the system. We're pissed off at our colleagues. We're pissed because no one's doing anything about this issue. And for me in this moment, I would say that the issue that I see is preventing preventable loss, preventing preventable perinatal loss, right? That is the issue here of it. Some losses are not preventable, but some are. And how do we work as a system to prevent preventable losses? That's a whole other presentation that I will gladly get into, of the public health issue there and all of that around perinatal loss. But right, that's that anger and rage. And so we're pissed off at everyone. We're even pissed off sometimes at other families that we're supporting because they see things differently than we do. And so the helping career, you either continue in and out of depressed and anger forever. In a trauma lens, we look at that as hyperarousal and hypoarousal constantly. We're just constantly going back. And so the part that we want to get to so that we don't leave this career, so that we can help more families, so that we can stay kind of present and in the moment, is this idea of the big picture. The big picture is we are one part of this ecosystem. We can do one thing. We can support one family, or, obviously we're going to support more than one family, but we support the people in our collective and we work as the ecosystem moves out. We are not responsible for changing the whole thing. And so when you get there, there's a point of acceptance, right? It doesn't mean that you're accepting that like we're not preventing all preventable losses, but it means that we are accepting that we're going to do the things that we can do to make small changes moving forward, and acknowledge that that's our place in this ecosystem, right? I can do what I can do. Kylie can do what she can do. All of these providers can do these other things, but we need to step back from that. Does anyone have any thoughts about that? Because for some people, when I explain the like stages of the helping career as seen as like compassion fatigue, it's just like eye-opening, like, ugh.
I feel for me, I want to learn more about this because I feel that this very much described my career as an occupational therapist. Okay, so if we want to read more about this, do we just Google stages of helping, or is there a book?
So I'm happen to be at my office, so I get to just be like, here's a book, because I'm here, because I can't work from home because children. So no one is in the office. I'm completely safe. I don't touch or see anyone. But I don't have a 4-year-old here. So there's this book. It's To Weep for a Stranger, Compassion, Fatigue, and Caregivers. I can write it in the comments of something, but it's the Compassion Fatigue Awareness Project. So that's one of the things.
It's super cool. So Jeanette says that it makes her think of the serenity prayer, right? Like, grant me the serenity to accept the things that I cannot change and change the things that I can, right? So is that correct? Not change.
And
This
it's not change the things you can. It's like
no, or okay, so someone want to write it for
Jeanette
us?
said yes. Okay. Accept the things that I can't change and change the things that I can. Okay.
Oh, and the wisdom
We
to
got
know
it.
the wisdom to know the
Here we
difference. Yeah,
go.
this is
Early
cool.
in my career, I was at a kids like group home, and that was one of the things on the like staff bathroom. It was like plastered on it of like, no, like you cannot change all of it. Stop trying. Try a little bit, small steps. Yeah. Okay. So risk factors, I said we would get to. Through the research, we're trying to figure out like how do we not have secondary traumatic stress. Okay, so the risk factors that they found in studying is 1, having empathy, 2, having experienced a traumatic event, 3, unresolved trauma, and 4, trauma related to children and babies. So if those are the risk factors, I, for one, don't want a provider that doesn't have empathy. So I would argue that in order to be a good provider, you need to have empathy. You need to be able to like put yourself in the person's shoes that you're working with and be present with them. But they're also saying that having empathy increases your risk of secondary trauma. So I think the choice then is you can prevent having secondary trauma if you choose to detach and not connect. But in doing that, we are not preventing preventable losses, because we know most maternal mortality, those losses are when the mother dies. It's because no one's listening. No one's present with the family. I would argue what we need within that piece is more empathy, right? How many families do we work with and they say like, I knew the moment and no one listened to me, or they dismissed me, or they said that like I was fine and the baby was fine. That's not always the case, right? We know that that's not always the case. That's a single point, but there's this like, maybe what we need is more providers that are empathetic and are willing to put themselves in their family's shoes so that they can listen more and be more present. And we need to then make sure we're taking care of our providers. Okay. Another factor that I like to talk about here is cultural implications. So just think, we're all helpers. We all got into a career to help people. Think about like your story that led you here, your helping thing, and think about like culturally, societally, what we're told. We're told to give until it hurts. We're told to always look for the helpers. We're told that love is enough. We're told like we are supposed to be okay and we're supposed to give everything, right? This is what we're generally told. We're supposed to suck it up and move on. Nurses often are literally told if they're struggling with a traumatic situation, they're given the next traumatic situation and told to just get over it, to move on. It's almost like throwing them into the fire because you want to make it so that they won't feel it and then they're not impacted by it, right? This is has been general practice with nurses in training. And what I see is that we're just re-traumatizing and re-traumatizing and re-traumatizing. And so even the good nurses, either they become disconnected and not present with their families that they're serving, or they leave the profession. And so it's not helping anyone in that, right? I also think in thinking about that is like implications for Black or Indigenous people of color. You know, they've historically, there's the role of caretaking for families. And so what does that look like and what does that mean? And like, how do we kind of pull out from that, like, everyone's allowed to experience this, and that our Black or brown counterparts and providers that are supporting us, they don't need to take on the brunt of it just because historically they've been in that place that they have, right? We need to be aware of that moving forward. Sorry, I'm like trying to side check the chat and see if there's anything worth or anything that needs to be responded to. Have you seen anything, Kylie?
I mean,
I think all just like valid points.
Yeah.
Yeah.
Yeah, and also
Sabrina, I agree.
I think also adding the layer of COVID on top of everything else right now.
Mm-hmm.
Like treating it, you know, if you're in nursing and you're having to treat COVID patients, and then another added layer.
The isolation, the like not having families. You know, there was, I'm curious how you're thinking about this, Kylie, but in July, there was a study that went out that talked about how preterm laborers were at a low because of COVID, or like during COVID, preterm laborers were at a low. And when I read that, all I thought was losses have probably had a rise, because there is a reason that we have preterm laborers when it's not healthy for the family, and the family goes in and says something's wrong, and then they deliver early because the baby's in distress, right? And so what happens when we're silencing that, because moms don't want to go to the hospital by themselves, or the pregnant person doesn't want to go to the hospital by themselves, and so they're avoiding going in, they're avoiding getting checked out. And so preterm laborers that are low for those ones, those that are like intervention preterm labors. And then what do our losses look like? And I'm hearing that from a lot of providers across the country, that they're feeling like they're getting a lot more stillbirths. I don't know, there's no research that I have seen on the numbers there, but that's just an anecdote, personal anecdote.
It's interesting.
Have you seen any of that or heard of?
I haven't heard any of that.
Yeah, I'm curious. Loving detachment.
Yeah, so we're getting some comments like, yes, we've seen more losses this year, and COVID's made it difficult to help those who have had a loss. I mean, yeah, Zoom is not an option. But I have also heard that people doing support groups online are getting more people to attend, because they don't have to go in like logistically, it's just easier for them. So I think it depends who it is. But we're doing support groups, and it's, you know, it's connecting people from all over the country, but I think even if you're doing it in your area. So
yeah. Okay, I want to move on because I'm looking at the time, and I told myself I would try to stick to schedule.
Okay. Okay, let's talk fast. Okay. How does secondary trauma present itself? So what are the symptoms? What does it look like in our daily lives?
Yeah. Okay, so general symptoms, you know, bottle up emotion, isolation from others, sadness, apathy sometimes, where they're just numb, not feeling anything. Often feels the need to voice the excessive complaints about management and coworkers, lack of interest in self-care, recurring nightmares or flashbacks, persistent physical ailments, difficulty concentrating, prone to accidents, debt or financial problems. The other thing here, like if we look at, PTSD diagnostic, intrusive thoughts, intense visceral reactions when reminded of the events, avoidance and numbing, hyperarousal, like that hypervigilance, having to be on top of things all the time, like not able to shut your brain off. Those three things correlated with functional impairment is what makes a PSD diagnosis. We can argue that most of our families probably meet those three things that we're working with. Most of our providers often will look at that as well. And so thinking about like, that's the PTSD criteria, is like the intrusive thoughts, the avoidance and numbing, hyperarousal, and then also functional impairment. What that means is varied. It's a spectrum. And so the trauma piece in me feels like I need to explain the nervous system response here and acknowledge that when we're triggered by something, which could be a thought, could be a memory, it could be we're working with another family, it could be a high-pitched noise, it could be someone touching our arm, it could be anything. Our nervous system responds, and we can go into that fight response that says don't just sit there, do something, that hypervigilance. The flight response, which is don't just sit there, get away, avoidance. The freeze response that says don't move, it's not safe. And so like dissociation, kind of checking out, depersonalization, just feeling like you're not yourself. When nurses disconnect, sometimes they're in that freeze response, they're going through the autopilot motion. And it isn't, sometimes it's great and sometimes it's not useful because they're not listening to the person in front of them, right? And so just understanding that like this is a nervous system response to not integrated trauma. Okay, so examples from daily life. What I see most often is people just feel like they're not present with their family. They go to work and then they come home and they're just checked out. They can't show up for family because what family needs feels silly or small compared to what's going on with their families outside of that. They're exhausted all the time. They're reactive. Rage is often a thing with family. And so it's more about like, what do we see when you're off the clock? You're not sleeping, you're sleeping too much, you're not eating, you're eating too much. Addiction and substance use is really high right now, specifically with the medical field. And so it's this like, a lot of times what I hear most often is they feel like they're not present and they're not themselves. And then we can kind of pull apart from that and say like, well, what's going on? What's on the other side? But they don't feel good. And they're navigating coping skills that aren't necessarily healthy. Kylie, do you see anything else there that might resonate with anyone?
I don't know if you mentioned it's just like irritability and like instead of with the family part, just like you're upset about something else, right? But you're taking it out on those that you're living with.
Right. How dare you ask me to help you with your homework one more time? Or whatever the situation is. I would really, so I guess let's move on to the next question and then we'll kind of go from there.
So it's 40.
Mm-hmm.
What do you want to
So
do?
we're kind of related.
Okay. Okay. So those of you who are like, I'm burnt out, I'm ready to leave my profession, I can't do this anymore, I'm done. What do we do?
What do we do? First, stop fighting it, and get to know yourself. really like check in with yourself and think of what you're feeling. A lot of times it's that we just need to understand what we're thinking and not fighting our thoughts over and over and over again. We spend so much energy trying to fight our thoughts and what we're thinking. We want to just kind of move through them. We want to process the events, talk about the events. Are you someone that journals? Are you someone that meditates? Are you someone that does yoga? Like, get in and do those things with the intention of thinking through the event or the situation that happened. And feel compassion for yourself and find empathy for yourself and just give yourself permission to nurture yourself over all of the other people that you're supporting all the time, right? You're supporting all these people. Give a little bit of that back to you. And so allow space for self-care, whatever that looks like. I'm going to give this little anecdote because I think it's important just for the comparable. When I tend to like have some secondary something, I tend to just constantly be ruminating over it and ruminating, like so much so that I'll try to bring it up to my partner and he'll be like, you can't tell me this stuff. Like, I can't know this, right? And so I took it to like a peer consultation. And as I was talking about it, I just started sobbing. And then as I'm like, oh, this is secondary trauma. Like it took me to like verbalize it to another person, even though I do this stuff, like this is what I teach, for me to be like, oh, right, this is what's happening. And then it just gives you another perspective to be like, oh, well, I know what to do there. But instead it's like, often it feels like when we feel stuck of how to help someone else, it's really about how do we lean into ourselves because we're the person that's stuck in that place. And so it's just giving yourself permission to process and to be, and whatever comes kind of comes out of it. From the research, and then we're going to get to a short activity for you guys, but from the research, the argument is the best gift a professional caregiver can give themselves is time to sit with the event and the emotions and just be still. It's the quiet moments that allow for integration. It is then that one will learn to use the tools necessary to develop the traits of mindfulness, focus, self-care. Mindfulness-based stress reduction is the most researched framework or theory for medical providers from navigating secondary traumatic stress. And really mindfulness-based stress reduction is being present and being aware and just giving yourself space for reflection and curiosity without judgment. And the second piece is that debrief, right? We talk about families. We know that families need that debrief after a traumatic event, specifically with medical trauma, to know what happened, to know why it happened, to know what they need to do moving forward. And that's also what we need. When we hear these stories time and time and time again, we need space to debrief. We need space to share and just to be authentic. And, you know, I would argue a good support group for providers, if there are no tears, it's not really helping. Like there needs to be tears, so it needs to be a safe space because we need to have that emotion behind it. Because that emotion, you don't show up with it in the room with the clients and the families. And so being able to show up in a safe space where you can be held, I think is really important. So we want to talk about just a short activity. I want you to find a piece of paper and a pen and just kind of breathe for a minute. And does anyone have any questions beforehand? Let's start asking the questions. I'll give you a little bit of gist on this activity, and then we can get back to answering some questions. Okay, I'm going to assume you all have a piece of paper. So if it's a piece of paper and a notebook, I want you to draw like a horizontal line across the middle and then 2 vertical lines down. So you have 3 like even spaced pieces. If it's not in a notebook and you can fold it like that as well. And so now you have 6, I said 3, but you have 6 even spaces, 3 on the top and 3 on the bottom. And I want you to label each of those at the top daily, then weekly, then bi-weekly, or every other week, whichever language you use there, monthly, quarterly, and yearly. And the idea here is to literally brainstorm what are all of the things that you can do for yourself to take care of yourself. And as providers, we need to get back to basics. And so in the daily column, I want you to write down everything that you could do daily to take care of yourself. And sometimes for providers, that is going to the bathroom when you need to go to the bathroom. It is drinking water. It is taking a shower, brushing your teeth. Like, let's navigate, where are you at and what are the things that you could do daily? And it might feel really basic, but like literally everything. Some people might put like they meditate daily or they do yoga daily or they read poetry daily or they journal daily or whatever it might be. That's awesome if that's something that you legitimately think you could do daily. Okay, and now I want you to move to weekly and do the same thing. And then bi-weekly, monthly, like bi-weekly and weekly, that might be therapy or going to the gym or calling a friend or playing on the floor with your kids for a minute, or it might be any of those things that we don't necessarily think about as self-care, but it is us really taking a moment for ourselves and intentionally doing something for ourselves. Monthly might be having a date with your partner. That might be quarterly, but it might be monthly. We're not going anywhere, so whatever that looks like in your world, having a date. Quarterly is the same thing. Quarterly might be having a day that you take a self-care day from work and you don't work for a day and you don't have any other real responsibilities. It might also be doctor's appointments, right? Like, do you need to go see your PCP or your OB or your dermatologist or the dentist or the chiropractor? Like, what are the things that you need to be doing to take care of yourself on that level? Quarterly could also be like doing a training or signing up for a webinar or going to something that you're seeing people. I agree, Sabrina. What type of things in a cognitive space do you need to be learning and to feel like you're growing as a yourself and a person? Because that is also self-care, nurturing our cognitive space. And so for me, quarterly is often like trainings or webinars or something like that. And then yearly, what can you do yearly to support yourself? Conferences was often one for me, of like making sure I went to a conference every year, because just being with people that are like-minded feels less alone and is you taking care of yourself. Yeah, and just kind of moving through that. And so I'm going to assume you guys all have something written down. So the next aspect here is to go back to daily. And I'm going to assume you have probably 10 things written down, maybe. Is I want you to circle the ones that you already do daily. So if you put brush your teeth on there and you already do that daily, like, let's circle that because it's already done. And then I want you to circle 4 more things on that list. Only 4. And then I want you to move all of the other ones to the weekly column. And then I want you to repeat that. So weekly, all the things that you know you already do weekly, circle, because we don't have to work on that. And all of the things that you think you could do weekly, I want you to circle, let's say 3. And then move the rest to the bi-weekly column, and so on and so forth. And the goal is, when we think about all the things, right, on New Year's resolutions, we think about like, what am I going to do to take care of myself? We come up with these ridiculous goals that we don't do. And then, we're 3 weeks in, we haven't done it. We don't pick it back up because it feels overwhelming and exhausting and we already have failed, quote. And so we want to make a self-care plan that's actually you can do legitimately to take care of yourself and not feel overwhelmed. Because of this conversation, I would encourage, like Kylie said, that you guys are doing, what is it? An Empowering the Provider group monthly, right?
Yeah,
So
well,
is
we're doing it for the month of February, once a week for the month of February, but we'll offer it again. But I was going to ask you, like, if someone wants a support
Mhm.
group, n- is it something that they need to start themselves if it doesn't exist? Like at their, I mean, it depends what their profession is.
Yeah. Um, I'm thinking. This is this like, I know our hospital nearby, they tried to have me come in to do like debriefing sessions with their labor and delivery nurses. But the reality is like it still doesn't always feel safe because it's still your place of employment. And so unless they have a really good place of employment that does have this and it does feel safe, it doesn't feel like your boss is going to be judging you. Um, I don't, a part of me is kind of like, maybe should we just create a support group? Should we create a debrief group um, for providers? Let's figure that out. But it's for me, it's kind of like a processing group as well. And so, but maybe there's one person that you work with that you can be like debrief buddies that you can call and be like, I just need to like process through something. Um, I know I have people like that at work that I'm like, I'm just kind of stuck on this thing and I need to process it through. Um, but something like that I definitely think would be beneficial. Or your own therapy, finding your own therapist, right? These are the things that we do.
So I just also want to acknowledge Sabrina made a point, but it was only to you and me that
Mm.
COVID has taken away so many self-care practices. And I just want to acknowledge that for so many of us, that is probably true. That what self-care used to look like isn't what it can look like now, and that your lists may be something that are different now than they would be a year from now. And so just acknowledging that part, it's things are different now. So
Mhm. Um, yes. And yeah, it's like pivoting to what that might look like. Serena also asked like what could yearly be? For me, yearly is usually like a conference as well as a vacation, um, or a sabbatical, just like not working for a week. This last year, it looked like going to a cabin in the woods in the middle of nowhere. Um, there's in Pittsburgh or near us, there's what are like getaway type things that you can go and it's like a tiny home cabin, right? And you can go and just like be away from the city for a little bit. But I think something like that of like what is it that you know that you need that you're not going to do monthly and you're not going to
yeah,
even do quarterly too much. And that could also be all those doctor's appointments.
yeah, but a way to detach and
Yes.
kind of like unplug from everything. Um, so please use this time now to, okay, so with the activity, I just want to encourage you all. We don't have a ton of time here. We're trying to keep it to an hour to respect all your times because we know that you're busy. But please take that and spend some time thinking about it when you have a little bit of time, like on the weekend or something. And and then we can use this time for questions. If you want to put your questions in the chat box. So Jody, I'll read you some questions and we can respond. So Jennifer is saying that she doesn't work in healthcare, but she volunteers. So when she's having a difficult time, it's hard to find someone to talk to.
Mhm. And I
Yeah.
I'm going to be completely clear there and just because the volunteer we all have that same problem because we feel very isolated in the work. Even like therapists, right? You come in, you see clients, and then you leave. Like we very rarely have this time where we're together. And so I think that that is also a universal piece. Um, I would like, are there groups around you? Do you have bereavement doula groups or birth worker groups or something around you that you could post and be like, I just need to debrief with someone. Does anyone have a moment? Um, I'm really surprised. I don't know if it's the same as it used to be, but Facebook groups, like for therapists and birth workers, like I, for a lot of time, I felt very isolated, just a solo practice. And so I would just like reach out and be like, I need to talk to someone about this. And like 8 experts in this field would kind of like reach out and connect. And of course, you have to take everything with a grain of salt because you don't know who those people are necessarily, and make sure that you don't share too much. But it was always really helpful to know that like there is a community even when we feel really isolated. I had started like 2 years ago a Facebook group for the perinatal provider, and I stepped away from Facebook for probably like 8 months now. So I like archived the group, but I could bring it back, and we could see if that could be a resource because I think we had a decent number of people in that group that was like for the perinatal provider.
Yeah.
So maybe that's something we should I should think about doing again.
Well, and then I would say also like when you are like you're volunteering, and are there other people that are volunteering with you? Like, is there one other person that's kind of more invested than others that you trust and you could confide in? I mean, I feel like that's what I do. Like I have kind of, one or two people that I work closely with, that I will, go over things, like things that are bothering me or issues, like they'll talk to me, I'll talk to them, that type of thing.
Yeah. Finding your little pod. Not a COVID pod, a debriefing pod. Do we have any other questions? Any other thoughts? Do you have any questions or thoughts, Kylie?
I'm just going through the chat box to see if anything else. So Barbara, this is a little bit a while ago, she just shared that she left her work in perinatal loss. I think as a nurse, I can't remember, I'm not going to go scroll, but that nursing students are not being taught about perinatal loss. And she said she found her way to work with this population was through being an educator. So that's another option, is like, where can you change? Where can you be the change and make that impact?
Right.
Um,
Thinking about
okay,
it,
so
that system.
yeah, the ecosystem. I like that. I like that analogy. Alana said on Facebook. So there are a lot of Facebook groups. Okay, so she mentioned one called the Trauma Informed Perinatal Professional. There's also like perinatal mental health providers, different things like that. Yes, and so this is being recorded. It will be up in our webinar shop for other people to watch. And if a lot of people registered and are not watching live, but we'll send a recording out to those people. And I will also say, just as a nonprofit, because of the generosity of our donors, we're being able to offer webinars for free now. But if you have a few dollars to spare, like a coffee, we would very much appreciate your donation to Return to Zero Hope, which can be done on the website. And I will follow up with the recording and a link to that as well. There's a few other comments.
A bunch came in at once. Can't read them all.
I know, me too. And it's noon. Okay, well, you and I will read them later. But Jodie, thank you. I mean, I feel like we could sit here and talk for hours, but this is a good kind of place to start, and hopefully just allow you all to do some thinking, some journaling after what you heard, working on your chart of self-care, and just be kind to yourselves, knowing that it's COVID and things are not as they always are. So it may look different this year. So Thank you everyone
Yeah.
for
And
attending.
just like we talked to our family, you're not alone. Sorry, there was a delay there. I said just like knowing with your family, like just knowing you're not alone is what we need. And you're not. This is common experience.
Okay, thank you everybody. I'm gonna stop recording.